what disease they're talking about. And so essentially the second part of the book was my description of what I think this systemic disease is that these people have, which leads at least 60 and maybe 80% of them to have heart attacks. And of course this is complicated and there's many factors, but I think you can get far by boiling it down into three main factors. So the first factor that causes people to have heart attacks is a disturbance or an imbalance in their autonomic nervous system. And of course, this is well known to cardiologists. That's why they use beta blockers to block the sympathetic part of the autonomic nervous system. But we now know with heart rate variability testing and other kinds of testing that in the days, weeks, and months leading up to people having a heart attack, they have a decreased tone of their parasympathetic nervous system. Now, I would admit that's similar to an increased tone of the sympathetic, but it's also not the same. And we know now that this decreased tone of your parasympathetic nervous system happens because of stress, it happens because of smoking, it happens because of inactivity, it happens because of poor diet, it happens because of moving to a new country, it happens for many reasons, diabetes, all of which we know contribute to people having heart attacks. So systemic disease number one is decreased parasympathetic activity. Systemic disease number two is a failure of the collateral or small vessel blood flow. And anybody who wants to look into this should go to that same website, heartattacknew.com, and then go to the frequently asked questions, and then go to the riddle solution, and then scroll down to figure 1, and you will see a picture, an actual examination in what a normal heart circulation looks like. And much to some people's surprise, a normal cardiac circulation does have these three major coronary arteries, but it has thousands or hundreds or maybe millions of small collateral vessels. In other words, as I like to say, the body is not so stupid to put all its eggs in those three baskets, and that having a blood flow based on more of a watershed than a river is a much safer and more redundant strategy, and it's much more likely to be the one that nature uses. And this then makes perfect sense of why people with 95% blockages can often and easily walk up hills, because they have a perfectly normal blood flow that is actually coming through where most of the flow comes from anyways, which is the collateral circulation. And this also makes sense of an interesting quote and fact that you hear from old-time doctors before this coronary artery theory became in vogue, which was they used to say that people with plaque buildup have less heart attacks because they have a more robust collateral flow. So the second systemic disease is a failure or a degradation of the collateral blood flow. And of course, most of us know this is generally a consequence of hyperinsulinemia, otherwise known as diabetes, or metabolic disorder, which is a disease of the small blood vessels, not the big coronary arteries. And this, of course, clears up the anomaly of why diabetics have more heart disease when there's no evidence, at least that I know of, that they have more plaque, but they certainly have small blood vessel disease, and that is a major contributor to having heart attacks. So that's systemic disease number 2. Systemic disease number 3, and in my view, the most important, is that in each case of heart disease, there's a lactic acid buildup in the tissues, which causes a localized tissue acidosis, which first causes pain and then actually causes necrosis or degradation of the heart tissue. And the way this goes is through a combination of autonomic nervous system dysfunction and then poor collateral blood flow, and in certain cases possibly a contribution from plaque buildup. Then there's a sort of a disconnect between the ability of the mitochondria, which then they can't get enough oxygen and use enough fuel, and so they shift, just like any tissue does, into generating fuel from the cytoplasm instead of respiring it from the mitochondria in oxidative phosphorylation. So now you have this sort of glycolytic shift where we start fermenting fuel instead of respiring it. And this is the same thing that happens in your leg. And just like in your leg where this process goes on, you build up lactic acid, you get cramps and pain, and then you stop moving your leg, and then the lactic acid gets flushed out, and then you're normal again. The same thing happens in your heart. There's this glycolytic shift. You start fermenting fuel in the cytoplasm. You build up lactic acid. You get cramps and pain in your heart. We call that angina. The difference between your leg and your spleen and your kidneys and your heart is your heart can't stop, so the lactic acid continues to build up. This acidifies the tissue. When that happens, then the calcium can't get into the cells, and then you see a localized paralysis or dyskinesis or akinesis of that area of the heart, which is exactly what you see on stress echoes and thallium stress tests. You see an area of the heart that doesn't move properly. That's because of the acidosis. The calcium can't get into the cells. That paralyzes the cells. The next thing that happens is that creates shear pressure in the arteries embedded in that part of the heart, which then breaks off little pieces, which the cardiologists erroneously finger as the cause of the heart disease. This is also why when this process happens and you get a localized tissue acidosis and it breaks down the cells of the tissues of the heart, we call that a heart attack. And then the shear pressure builds up in the arteries, and that's why, as Baroldi said, you see the development of clots after the heart attack, not before. And so that explanation fits with all the observed phenomena around heart attacks, and it's a perfectly reasonable explanation for all the things that we can see with heart attacks. And so I think that is an explanation of this systemic disease that we call heart disease.